Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. I read to the speaker, Dr. Muhanna, and all participants for today. Before we begin our session, let us start with the recitation of Kitab Al-Fatiha. To all participants, please fill in the Google form or the start point via the link provided. And without further ado, I would like to invite our speaker for today, Dr. Muhanna, to start the session.
Bismillahirrahmanirrahim. Thank you to Mr. Person. Assalamualaikum and a very good morning I bid to everyone. So without further ado, let us proceed to the presentation. Can you see my slide in full presentation?
Yes, we can see a slide.
Alright. So our today's presentation is about dengue fever. It is actually a relatively easy topic, but very important, especially during our relative. Okay, so this is introduction. I think all of us know this. Basically, it is a tropical viral disease. It lives in tropical subtropical region, and important thing to note is that they have 4 distinct serotypes: Dengue 1, 2, 3, and 4. Because of this, all right. Okay, is it better? All right. I'm sorry. Okay, so because of these 4 distinct serotypes, so that's why we do not currently have one vaccine that can target all of this. We have one, dengue vaccine, but it's not really widely accepted yet. Okay, so know that the first time infection will confer a lifelong protective immunity to that specific serotype, but not to other. And then secondary infection of dengue is actually a risk for them to get a severe dengue fever. Okay, this is basically all we know about the virus infection. First, we have incubation period where they relatively do not do any harm to our body. So 4 to 7 days, range 3 to 14 days, and then patient became asymptomatic and then became symptomatic. So know that dengue is it's a systemic. It can target any types of tissue in our body, and it's really dynamic. The condition of patient can change within minutes and hours. So and due to that, they have also various clinical manifestations. Some of them may have undifferentiated mild febrile illness, do not necessitate any admission, but some of them may then progress to severe disease with or without plasma leakage and organ impairment. Okay, this is WHO dengue classification. It's very important to understand and memorize this. Favorite question. So we have this in terms of dengue. If you are interested, you can look up the case definition for dengue. If you already done your community medicine, so we know that every disease we have this case definition. So in dengue we have probable dengue and also confirmed dengue. It's quite long, the definition. You can go back and read in CPG at appendix. But for probable dengue, what you have to ask is about first is the contact, whether patient live in or travel to dengue endemic area, and then patient have to have fever, high grade fever, and 2 of the following criteria, which is all of the symptoms. And then dengue is considered confirmed when the laboratory, the RCT or the ELISA come positive. And then this warning signs, we can go through this after this. So this is what I want to emphasize on. So this 2009, they classified severe dengue is when patient have whether severe plasma leakage or severe hemorrhage or severe organ impairment. So if patient have any of this, patient in shock, patient have some liver involvement hepatitis. So consider patient as severe dengue. Alright, this is pathophysiology. I think we all know, but this is very important for us to macam rearrange our thoughts once we understand this pathophysiology. So first, we have infection with virulent dengue virus, and then this virus cause an increase in vascular permeability. So that means that the plasma can go out from blood vessel to the extracellular compartment. So and then the immune system will be activated. So we have this, all of the inflammatory cytokines will be released by the body, TNF-alpha and so on. So this further increase the leakage of the plasma to the extravascular compartment. So what happened is that we see the plasma leaking to the outside, so the blood vessels become concentrated, hemoconcentration. So and then it will lead to generalized vasoconstriction. The vasoconstriction is where due to sympathetic activation, and after that, because we know that we need blood for tissue to yeah. Okay, sorry for interruption. Okay, tadi kat mana? Alright, so because of this vasoconstriction, then there is not enough blood to supply the tissue. So we know that inadequate tissue perfusion will then activate the anaerobic glycolysis and lactic acidosis. Subsequently, kita kata further depress the myocardium and further hypotension occur due to low cardiac output. Faham kan? So basically lactic acid lah yang menyebabkan the heart activities is not so efficient. So further, because of that, kita kata cardiac output become low. So of course BP become low, and then kita kata accentuate lagi the shock. Okay, so this is the clinical manifestation of vasoconstriction. I think all of us know. So just a revision. So it came from the brain. Because of not basically you kena ingat what happened if there's not enough of oxygen to this organ. So in brain it causes lethargy, restlessness, and then in the lungs, the kidney, and then the skin, coolness, pallor, this peripheral lah, delayed CRT, poor pulse volume, and then kidney will be kita sacrifice lah. First it will conserve the urine output, oliguria, and then subsequently anuria, and then to the cardiovascular and this, right. So complications. So complication is important because although it is dengue is very common disease, but we have to watch out for these complications. So first is massive bleeding. Patient can present with bleeding, usually kita dengar macam upper GI bleed, and then multi-organ involvement. I'm sure that you will learn further of upper GI bleed nanti during with Dr. Hanani. And then multi-organ involvement for HBS is important. Hepatitis, that's why patient have abdominal pain, kan, kita kata loss of appetite, vomiting semua tu, acute liver failure, and then CVS. This is important. Basically CVS involvement is due to kita kata shock component. So cardiac dysfunction, it can be manifested as arrhythmia, myocarditis, and of that. CNS is important also because once patient have CNS involvement, we can say that of course it's severe, but the complication of that involvement, what we're afraid is that the increase in intracranial pressure, increase in ICP. So encephalopathy, encephalitis, meningitis, and all of this. So for renal, of course, AKI, MSK, musculoskeletal system, but usually is more on apa kita kata relatively not permanent, okay. But then note that rhabdomyolysis can cause AKI also. So ocular and so on. DIC is this disseminated intravascular coagulation, and hemophagocytic syndrome is basically a syndrome due to extreme immune activation. So all of this cytokine storm and yeah, okay. So I don't think you have to memorize all of this, but it's good to know. Yeah. Okay, so for clinical presentation, so from this onwards is very important. So remember that dengue presentation is non-specific. it can mimic other disease. So that's why diagnosis is very important for us to differentiate whether this is dengue, leptospirosis, malaria or others. And it is very variable. No, kita kata one patient is not similar to another patient. Even if both of them are dengue, but there must be some differences between them. So it's very dynamic, it can change. That's why monitoring is very important in dengue. And then it's systemic, it can attack any other tissues in the body. So this figure is very important. To understand dengue, it's crucial to understand this figure. So mari kita tengok kan. So dengue, so we have three phases: febrile, critical and recovery. So in febrile, patient is febrile lah, demam. So you can see that this patient have high grade fever. Actually, it can lasting up to 5 days according to patient lah, but for the sake of this figure, up to 3 days. And the issues that we have to note in this febrile phase is dehydration. And then organ impairment. So note that I didn't include the pathophysiology of organ impairment for each organ tadi tu, but then you can go back and read. So we can see that organ impairment ni ada since in febrile phase, because organ impairment is not only due to plasma leakage, because we know that plasma leakage ni is very prominent in critical phase, but then you can see that some organ impairment also occur during febrile phase, because some of organ, the pathophysiology is due to direct, kita kata, action of the virus, and also due to immune activation and other pathophysiology. So the organ impairment can occur at any point of the phase, but more commonly in critical phase. And then we see at lab changes and serology, but I think I will proceed with kita tengok ke arah ni lah kan. So we can see the temperature in febrile phase is very high. Once it drop, we say that patient currently in critical phase. So and then usually critical phase lasts for up to 24 to 48 hours, 2 days again, and then patient in recovery. So the issues that we have to note in febrile phase, dehydration, like I mentioned before. In critical phase, because the plasma plasma leakage is increasing, so we have to worry about shock. And we know once patient is shock, it can precipitate bleeding. And then in recovery, because we know that the treatment of dengue is fluid. So in recovery phase, we have to watch out for reabsorption and fluid availability, because plasma leakage have stopped during recovery phase. And if we do not alter our treatment, the fluid therapy, so patient have kita kata tendency risk to have this complication of fluid overload. Okay, in lab changes. So banyak lagi lab changes that we have to know, but this the two most important, platelet and hematocrit. So hematocrit. So ingat, hematocrit is basically our RBC, red blood cells. So bila when it increase, it means that it is concentrated. So in critical phase, when plasma leakage is very prominent, so we can see the hematocrit increasing in nature. So maksudnya concentrated, the blood is concentrated, and then it comes down once the plasma leakage stops. Platelet is kita kata contradictory to that. So in the febrile phase, platelet may be relatively maybe normal, maybe coming down in the trend, and then in critical phase, they can drop really low. That's why patient have increased risk of bleeding. And then serology and virology. So we know this. Tak payah ni nak terang nanti. So this is just a word for whatever that I mentioned before. You can go back and read. But I would like to focus on this critically. So we can say that in critical phase, it's the manifestation is varies. So if patient have just minimal leakage, so the symptoms is transient and recover spontaneously. But if the leakage is very severe, so usually patient can become shock, compensated or decompensated shock. And before this shock, usually patient have these warning signs that we will go through later. So this is the lab investigation. All right. So this is the picture of the classical ni here. Nak sebut dia Isles of Wight in the Sea of Red. You can see that whitish area here. Macam pulau tu kan. Okay. So pulau putih, di lautnya merah. So this is classical one, but not necessarily ada kat situ. So if patient have this, no, currently patient is in recovery phase. Okay, so this is warning signs. It's very important. We have this mnemonic for to help us to remember this. So first is clinical fluid accumulation. So here, the third space fluid accumulation. The more common one is ascites and pleural effusion. So we can detect this during physical examination and also by ultrasound. And then R is restlessness and lethargy. We know that the brain perfusion is becoming low, and then abdominal pain. Usually abdominal pain ni is very important because waktu ni we have to differentiate with this abdominal pain because patient can come with very kita kata severe pain. So it's very important to differentiate whether this is dengue fever, acute abdomen, kan surgery, gynecological, also ataupun IM macam DKA. And then mucosal bleed, patient can present it with GI bleed, epistaxis, nose, and then also macam melena, or also patient can present it if it is female, kita kata menses to becoming more lagi banyak. I'm sorry, I'm lost of word bagi ni. And then last is P is persistent vomiting or diarrhea. So here is at least 3 times over 1 day. And the liver enlargement and tender, elevated hematocrit and dyspeptic. So elevated hematocrit, we have to remember the value, unfortunately, but it's very easy. So first, look whether the patient is female or male. If patient is female, we take at 40. If it is male and young, so it is slightly kita kata high, which is 46. And if it is elderly, so it's 42. Okay, so this warning sign is important because if patient have warning signs, is warning for patient, warning to us that patient may develop severe dengue, which then lead to shock. All right. So this, I really like this table. So table of pathophysiological changes from normal circulation to shock. So we have this. I will share a slide later, a slide done. Okay, done by I think by Ministry of Health. So it's a really long slide, 200 pages, but you can read it. Yeah. So it will explain further on the what happened in each kita kata the physiology lah. So first we have brain perfusion, so consciousness. So in normal circulation, patient kita kata is not confused, can answer our question. In incapacitated shock pun patient can still kita kata have clear consciousness. But then once patient become decompensated, we have this altered mental state. So know that one of the patient kita nampak dah confused, waktu tu dah kita kata dah lewat, is a late stage of shock, patient in decompensated or hypotensive shock. And then we have peripheral perfusion, so maksudnya the skin. So we have to check the CRT, the periphery whether it is warm or cool, and then the pulses. When we have also this nak tengok cardiac. So we have to look at the heart rate, the BP, and also pulse pressure. So in pulse pressure, it's very important pulse pressure ni, because once kita kata pulse pressure to becoming low, less than 20 mm mercury, so maksud dah late stage. So that's why the initial signs of shock is that raised diastolic pressure and narrowing pulse pressure here. So and then is after that is normal respiratory rate. So respiratory rate basically why there is increase in the respiratory rate, because of we know that dengue tadi cause lactic acidosis. So acidosis akan cause metabolic acidosis. So we know the compensation from that is the respiratory compensation. So patient akan become mencekik ni lah. And in the late stage become ni lah small breathing. Okay, so urine output is the kidney perfusion. So from here we can see that relatively semua macam normal. In incapacitated shock, basically everything is changed except for these two. So the brain perfusion is still maintained and the BP is still maintained, but the difference is that there is raised diastolic pressure and narrowing pulse pressure. Okay, and decapacitated everything dah change dah. So alternative state ada and BP dah becoming low. Alright, so kita dah done dengan what is dengue and the clinical presentation semua tu, and after that how to we confirm the dengue, to diagnose dengue. So we have these four ways to diagnose dengue, but then kita kena tahu dua ni lah, rapid combo test and dengue antigen serology test by ELISA, because these are the two yang most commonly used lah. So the first is rapid combo test. So rapid combo test ni, lupa nak masukkan gambar. So basically it will detect three things. First, detect the virus. Second is the antibodies IgG, and third is IgM. So because of this, dia punya detection window is longer, and false positive possibility is very low. Not very low, is low. So, but then this caution, the test must be read within specific time. Do not read it too late, because the test will not be, kita kata, boleh guna lagi. I'm not sure apa sebenar. It's not it's not valid anymore. Sorry. So this is rapid combo test. And then second is antigen, NS1, IgM, IgG. So in NS1, so we can see that the NS1 will be present early from maybe day 1 pun, but then the detection tu becoming drop after day 4 to day 5. So because of that, know that if patient come presented with fever, 5 days of fever, we can still do NS1. But then if patient presented with 7 days of fever, waktu tu non-structural protein 1, NS1 is not really kita kata effective anymore. And if it is positive of day 5, it predicts severe dengue. Next is IgM. So IgM, it will raise after the NS1. So it will peak is about 2 weeks, and then it will go down until 90 days. IgG, on the other hand, dia akan muncul, appear after IgM production, and then after day 7. So dengue via RNA detection is basically we detect the RNA using the real-time PCR. So we don't really use this if the usage is that for basically for to determine of the circulating dengue serotype in country, because for the epidemiology study, and it's also used as one of the diagnostic tools. Contoh macam if patient really fatal and patient die in postmortem case, we can also do this viral RNA detection, and this is disadvantageous because it's costly, not widely available, and we need some special instruction. So virus association is the gold standard, but it's only used for this research, surveillance, and genotyping purposes. Alright, this is one of the slide that from science cakap tadi tu, from MOH. So it's very easy to understand berbanding ayat tadi. So we can see here, Allah Akbar. Sorry. So we can see here, viral RNA kan, this is viremic phase up to day 5 here. So antigen to the coming down. So we can see NS1 up until about day 3 to day 5, but then nampak the dotted line means that the detection rate to dah becoming low after day 5. So and then after NS1 is kita dropping down, so IgM started to raise. So peak at 2 weeks here, to ruin before 90 days. Then IgG is after that about day 7 to increasing in nature, and it will stay there in our body. So this is in secondary infection. So in secondary infection, important to note that you can see that the peak of IgM. So in primary infection, the peak is much higher. The level of the IgM is higher compared in secondary infection. The theory is that because of the presence of the remaining IgG from the primary infection, that's why IgM level is relatively lower compared to primary infection. And sometimes it will detect it later. Contoh in primary infection, we can detect IgM maybe around after day 5 tu, we can detect the IgM. But then in secondary infection, maybe at day 7 only that we can detect some IgM. Okay. And we can see the IgG in primary infection is lower, but then in secondary infection, the IgG is kita kata raise up to the sky, the level. So this is two important things to differentiate between primary and secondary. So this is summary from appendix in CPG. Patient come with severe fever less than 5 days. We do this. Once positive, it's acute dengue infection. But then if it is negative, we cannot really rule out this. So send for dengue IgM. If more than 5 days, we send IgM. If positive, of course, it's a recent dengue infection. But if negative, we cannot rule out yet. We have to send after 7 days of fever, dengue IgM, because some of the patient kita presented late, dia punya IgM to raise a bit later. And then, or we can send for dengue IgG, because if dengue IgM is negative, so we have to suspect whether pertama antibody is not produced yet, or second patient actually is in secondary infection of dengue fever. So kena send dengue IgG for confirmation. So if fever more than 5 days and we already send the NS1 and IgM is negative, so we have to send dengue IgG. So it's positive, elevated in acute or past infection. This title I'm not sure nak kena ingat ke tak. So one nisbah 256 2560 ni basically nampak tadi a very high level of IgG indicate of secondary infection. Alright. Management. Okay. So for management, first, the flow is that we have to triage the patient, and then into inpatient or outpatient, and then baru kita tengok management of fluid. Okay, so for triage ni, I think we know basically we want to classify patient whether we need urgent attention or not. So this is, if you can see dekat ED, in emergency department or in KK pun, depan tu kita ada satu counter, registry counter tu akan buat triage. Once patient datang dengan history of fever, contoh, okay, datang demam dah 3 hari. So this is important things that to ask: history of fever, abdominal pain, vomiting, dizziness, fainting, bleeding. So basically kita nak confirm lah to suggest dengue, history of fever, and then tanya tentang warning signs, and then tanya tentang kita kata perfusion atau complication of that bleeding dengan dizziness ni. So parameters to be taken. Important thing that we can do at the triage counter is mental state, GCS level, BP, cctvr, and respiratory. So what is cctvr? cctvr is very important. Ni memang common and very famous we ask. Ya Allah. Okay, forgot about this. So the 5-in-1 maneuver, magic touch. So basically in 30 seconds we can recognize the early signs of shock. First we look at the ambil tangan patient, look at the color. So macam mana, is it pink or not, or blue? So we can know that patient in shock or not, decompensated or compensated shock. Scaffold inferior time, CRT, bila kita pegang tangan tu, okay, ni actually they have three places to check for CRT, but then for the purpose ni, usually we check at the whether in nail bed or in the finger palm. So you can choose. Another one is at the hypotenuse, but ini tak common sangat. So jangan sebut dalam exam. Just a finger palm and also nail bed. And then temperature, and pegang sikit whether it is cool or warm peripheries. And then V is for pulse volume. And kita palpate the pulse. Is it the volume is low, or is it enough, or is it enough? Is it large or low? And then how do we know this? We compare with our pulse volume lah, provided you are a normal and not in dengue or shock anything. And last is pulse rate, and calculate the pulse rate. So in 30 seconds we can have this early signs of shock. So after that, we have to know to dispose patient, maksudnya when to send patient. So if patient is stable, we send to green zone, and then if patient is compensated shock, we send to yellow zone, and if it's decom, we send to critical zone, the red zone. But then we know that triage is ongoing process. Patient can deteriorate. Maybe patient early on come to the green zone, but then after dah tunggu about 5 to 7 hours, maybe in ED tiba-tiba, okay, they deteriorate, become yellow zone, so dan sebagainya. So this is the approach to elevation of dengue infection. So actually nak buat session of history ni, but itulah takut tak sempat. So just know that in dengue fever, in exam ataupun in MBBS, it's important for us to present the case. Kita kata in order for the examiner to understand the chronology, the chronological process, the fever, when does it start, and then how many days of fever, and then warning sign to start bila, because it's very important for us to categorize this patient currently in what phase of disease, of illness. So after that, we also have to ask about the oral intake, because this is very important for the management plan nanti, whether we want to admit patient, want to give intravenous, or just encourage increase oral intake. And then of course the ask about the complication, maksudnya whether there's any bleeding and any organ involvement and of that. And urine output is very important. Urine output dengan mental state atau seizure ni, because this is two kita kata organs. Once patient have mental state, So, and the urine output, we know that if patient dah tak boleh nak kencing, oliguric, so patient is in shock. It's very important to ask about frequency, volume, and time of last warning spot. Sometimes patient cannot really give history, all of this, but yeah, take what we get. So other important relevant history that we have to ask is about contact, because tadi nampak definition of probable dengue is they have to have this contact with history of dengue, and then consider other differential diagnosis, lepto, typhus, and malaria. That's why we have to ask about jungle trekking, swimming in waterfall, traveling, and recent unprotected sexual or intravenous drug user for acute HIV, seroconvulsion illness. Sorry. And then for comorbidities, this is kita panggil risky groups. Patient with pediatric patient, pregnant patient, obese patient. Comorbid ni macam DM, hypertension, renal disease, kidney disease, or social factors. All of these are risky groups for them to have severe dengue ataupun to have a complicated case. Okay, and then after we take history, we have to do physical examination. Ingat, in physical examination, we start from atas, mental state GCS score, and then hydration status, and hemodynamic. So in dengue, please remember this cctvr and vital signs, of course, blood pressure, pulse pressure, semua tu, and respiratory rate. Last kali we complete with the all of the other system. But this is the important thing lah nak kena buat, which is the abdomen. So in contoh dapat kes dalam EOP, because we do not give dengue case in pro exam. So do kita kata general examination, the cctvr, and then do an abdominal examination for abdominal tenderness, hepatomegaly, and ascites. So investigation. So we send for full blood count and hematocrit, and then we confirm the dengue by do the rapid combo test, RCT or Nelson antigen. Alright. So once we're done with our history, physical examination, and also the investigation, actually the investigation there are some more that important, but this is the most important thing. And then the full diagnosis. First, we have to ask ourselves whether is it dengue or something else. Can we actually lepto? Because ingat something yang Dr. Ina say, kalau dengue, usually you put on top most of our macam differentiation if it's less than 5 days or less than 7 days. If it is more tu dah less likely becoming dengue. So less than 7 days tu anything can is possible. It can still be dengue, it can still be lepto, it can still be malaria. And then which day of illness. So berapa hari je ni, and then which phase patient is currently in, whether it is in febrile, critical, or recovery, and is it severe or not. Macam nak tahu severe or not, first are there warning signs, because as mentioned before, warning signs usually present before a case of compensated and decompensated shock, and then whether the patient is in shock currently or stable, and ada tak organ involvement, is the AST ALT increase, ataupun is there any bleeding, is there any CNS involvement. Alright. So the full diagnosis usually macam lah, we say that patient is contoh is a severe dengue in decompensated shock currently in the contoh in day 6 of illness, in critical phase contoh with warning signs of vomiting, diarrhea, and abdominal pain contoh lah. So after that, after we look at the full diagnosis, and then we have to determine patient ni we want to admit or not. So for patient yang mudahnya, if patient can eat well, can tolerate really well, is not in shock, stable, no warning signs, no bleeding, and then the investigation is okay, stable HCT, so we do not have to admit patient. We can manage patient outpatient in KK lah. But then if patient ada warning signs, bleeding manifestation, cannot tolerate oral fluid, ataupun ada any other organ involvement, semua ni, organ failure, shock, bleeding, ataupun in case of special situation yang risky group tadi yang we mentioned before, we may consider to refer to hospital and admit. So this is the lab criteria. So kenapa kita risau dengan stable serial HCT dan juga rising HCT ni? Because if patient is in stable serial HCT, so kita kata patient kari the plasma leakage tu is controllable, minimal leakage. But then if the HCT is rising, so the plasma leakage is very prominent. So kita risau patient akan becoming shocked if we do not admit and start on the kita kata fluid therapy. Alright. So after that, after kita dah decide dia nak admit ke dia outpatient, saya lupa nak cakap ni, it's about notification. So remember, dengue is one of the disease that we have to notify to the pejabat kesihatan, district health office, DHO, within 24 hours. And if patient is not indicated for admission, kita kena bagi tahu patient datang klinik setiap hari, daily follow up from day 3 of illness sampailah patient febrile. Until patient is febrile for at least 1 to 2 days without antibiotic, baru kita boleh discharge patient. Tak perlu datang dah klinik, cik. Okay, so every patient they have this outpatient dengue monitoring record, and also we have to give the home care advice they play. Alright. So this contoh dengue monitoring record, dia berbeza lah ikut ni. Usually the relatively macam ni lah. So we have the date of fever. Kita akan track lah about ni, because we want to track patient ni currently in what phase, and then is there any indication for admission or not. We know that dengue is dynamic, so tak semestinya once patient is an outpatient patient, kita tak akan admit dia. Mungkin at first we treat in the clinic, but then subsequently mungkin HCT tu rising sangat, platelet becoming so low, so we have to admit patient. Alright, so this is the dengue assessment checklist. Can go through later. Basically every patient akan ada benda ni before they send to the whether outpatient ataupun in the ward. Alright, so this is the home care advice. Boleh tengok juga nanti. So basically apa yang saya nak tekankan ialah tentang fluid intake. So ingat, bagi tahu minum air banyak. So 2 to 3 liters average adequate fluid intake, and then control the fever, because unfortunately cakap semua orang tak ada ubat ke dengue ni. Unfortunately kerana ni kita tak ada ubat yang boleh hilangkan the virus, sama juga macam COVID-19. So bed rest, fluid intake, and control the fever. Avoid the mosquito lah. Alright, and then watch out, bagi tahu patient when do they have to come to hospital atau to come again to see us. If patient have bleeding, patient have all of these warning signs, and then drowsiness, and also difficulty in breathing. Right. So this is summary what happened in ED. So once patient datang in ED atau in KK, so triage the patient, nak hantar dia pergi mana, outpatient versus inpatient, and kalau nak admit, which zone before kita admit tu, kita decide whether it is red, yellow or green, and then always do a continuous assessment and monitoring, because patient can deteriorate. So contoh macam patient, kita consider whether to down triage the patient or up triage the patient by ABC, cctvr, vital sign, and also the input output chart. So lab test ini yang saya cakap tadi. The important thing dalam ni, dalam exam ke apa, ataupun kena ingat FBC, hematocrit dengan rapid combo test. And then subsequently kita kena buat yang ni in case of nak admit tu. So blood gases, ABG and serum lactate ni untuk detect for metabolic acidosis. LFT, AST ni liver function test for the liver involvement. Kena ambil juga kalau patient tak severe pun for baseline. And then RP also baseline juga. And also because we want to give fluid to patient, CK, myocarditis and rhabdomyolysis, and lastly GXM, group cross match. So this is for patient in shock. We have to kena watch out, anticipate that mungkin kita perlu transfuse blood to the patient. Alright, imaging is we suspect vascular leakage. We can do chest X-ray, look at the pleural effusion, and ultrasound to look for other part lah, for third space loss. Maksudnya nak cari pericardial effusion ke ascites ke. And then last is to assess collapsibility of IVC. If you remember in ED, dia orang macam ada fast scan kan. I think ada tengok juniors yang belajar fast scan doktor dulu, kita orang tak pernah belajar fast scan tu. So but then we learn it sendiri lah. So basically it's just like a fast scan basically. Kita nak tengok several compartment of the body, look for the fluid, and then kita tengok dekat, we look at the IVC, because if there's not enough of fluid in the IVC, kita kata the turgidity of IVC tu lembut lah, so dia collapse, faham ke? If there's enough of fluid in there, so it's not easily collapse. Kita tekan the probe, and then kita tengok the diameter, the difference in diameter. I think saya dah masukkan, nanti kita tunjuk nanti. And last is appropriate fluid therapy. Alright, so make sure give patient fluid before you send them to the ward. Stabilize the patient. Alright, last is fluid therapy. Okay, so before we go to fluid therapy, macam biasa, we have to know whether patient is currently in shock or not. If patient in shock, non-shock patient, kita kena tengok patient to, if patient have no comorbidities and can tolerate orally, so we just encourage adequate oral fluid intake of 2 to 3 liters daily. Minum air banyak-banyak. And we do not necessarily give IV fluid therapy. But then some of them mungkin akan consider IV fluid therapy. So siapa yang akan dapat IV fluid therapy ni is patient who cannot tolerate oral fluid. So macam mana kita nak suruh dia minum air kalau dia tak boleh minum air? Faham ke? So if patient is vomiting ataupun dia ada severe diarrhea, maksudnya maybe patient can tolerate orally but then too much of loss compared to intake. And then the second one is if the plasma leakage tu nampak becoming more severe, maksudnya the hematocrit is increasing walaupun we ask them to increase oral intake, but then the trend is worrying us. So we may give IV fluid therapy in this non-shock patient. So how much of fluid that we want to give to patient? So this is the formula. Previously, ini CPG 2015. Previously yang 2000 berapa tak ingat. Yang second edition, kita guna holiday segar formula and 40-30-20 tu. 432 tu. And in current CPG, kita bagi 1.2 hingga 1.5 ml per kg per hour. So if patient is not obese, if patient is obese, we have to adjust body weight. Because of time constraint, saya tak present the slide of how to calculate, but it's relatively easy. We start with 1.2. If it's not enough, kita up sampai 1.5. This is per hour tau lepas kira. So contoh kita ambil 1.5 times 50, kita dapat contoh lah. Don't remember. So telah dapat 200 cc contoh. It's per hour, and then we have to times 24 hours to get 1 liter, how much of fluid that we want to give to patient. So remember that not all patient yang we give fluid ni, they cannot drink. If they can drink, ask them how much of fluid that they can consume. Contoh, they can consume 500 cc contoh. So we want to give fluid for 1 day, contoh kita nak bagi 1800. So kita kena minus with the 500 cc that they can consume so that we do not give extra fluid to them. Faham ke? Harapnya faham lah. So reminder. So we have to frequently adjust the maintenance fluid regime during the critical phase because during this time the condition of patient is not stable. It can easily deteriorate. Sekejap Okay, sorry. So during critical phase, we have to increase the normal maintenance. So 1.2 to 1.5 times the normal maintenance increase because kita tahu critical phase ni more fluid is lost. And then know that not necessarily once patient have IV fluid therapy, they will get IV therapy kita kata for the rest of dengue fever illness. Sometimes bila dia dah boleh tolerate orally, so we switch on the oral fluid. That's why adjustment is very important. And then about graded fluid regimen. So graded fluid regimen ni basically maksudnya kalau IV fluid therapy that I mentioned before, kita bagi macam sekali harum, maksudnya one time tu kita bagi terus one bolus. Graded fluid regimen is where we give the fluid in subsequent step. So in patient with persistent warning sign with increasing or persistently high, maksudnya the trend is increasing, so we may consider graded fluid regimen. So what we do is that we give the crystalloid solution, the 0.9% saline ni, we start with 5 ml. So this is the magic number you have to remember. Sama je nanti to every case, shock ke tak shock ke, 532. So start with 5 ml per kg per hour and then kita reduce to 3 and then reduce to 2. Okay, according to the clinical response. Kalau patient tak respond, jangan pula reduce pula. Patient respond, baru kita reduce. Alright. So kita aim the urine output ni 0.5 to 1.0 ml per kg per hour. So always give fluid, assess and respond, repeat the HCT and review whether to kita kata reduce the fluid ataupun kita nak increase the fluid. Alright, ni I think I will skip. Tak cukup masa. So this is the case definition of dengue hemorrhagic fever. So ingat WHO keluarkan this definition because for them to diagnose dengue shock syndrome, the patient have to meet pun. Basically But then it's good to know lah, because yang ni selalu tanya about tourniquet test. So previously macam kita kata to diagnose hemorrhagic fever, patient have to do tourniquet test. So I think you know this tourniquet test, simple je. We do macam take BP tu, inflate the cuff for about 5 minutes macam tu, and then we deflate and wait about 5 minutes. So if patient have thrombocytopenia, kita akan nampak some of the PTK in the hand lah. More commonly in the antecubital fossa and also at the wrist. So more than 10 PTK is diagnostic per square inch. So previously it's very important because we cannot really get the platelet level tu macam as soon as possible. So this is actually a quite good test for us to know what patient is thrombocytopenic or not. Alright. So this dengue shock syndrome can be graded into grade 1, grade 2, grade 3 and grade 4. So for dengue shock syndrome, grade 3 and 4 ni lah yang currently kita kata as dengue shock. Do you understand about that? Alright. So dengue shock syndrome is medical emergency. We have to recognize signs of shock at early stage. We have to give fluid resuscitation promptly, and we should manage patient in high dependency and ICU. The main treatment is IV fluid therapy. And in case of intractable shock, colloid is preferred compared to crystalloid. Okay, this is sama juga the table tadi. Just know that tadi kita dah bincang tentang how to manage outpatient patient. Next is how to manage shock patient. So this kalau tak ingat tadi case definition yang berlambak ni, tak perlu. Just know that once patient ada these signs of shock, so patient is in shock. So patient is dengue shock. So we have 3 algorithm in CPG. Kita kena tahu patient compensated shock or not, decompensated shock, ataupun patient is in decompensated shock but then ada suspicious of bleeding ataupun ada leaking. So this is algorithm A. Okay, nampak tu je dah. Alright. So first kita kata kita tengok patient, assess the patient. Oh, patient is compensated shock. So maksudnya apa? Every parameter tu dah ada changes except for the altered mental state dengan for the BP. So BP is still normal, patient is still conscious. Alright. So waktu ni, but then the pulse pressure is becoming narrow and the sleep is increasing. So this kita kena guna algorithm A. Okay, so algorithm A, the fluid resus is 5 to 10 ml per kg per hour over 1 hour. Alright. Kena ingat ketat nombor ni. If you fear, kena ingat nombor ni. Alright. So after that, we obtain the FBC, hematocrit semua ni basically as a baseline and also for us to monitor after this. And then we see whether patient improve or not. So what does it mean by improvement? It is by clinical response, lab parameters or imaging parameters. Clinical response ni basically all the parameters yang dalam table tadi, all of them, they improve. Maksudnya mental state improve, paraphrase becoming warm, CRP becoming less than 2 seconds, and all of that. Lab parameters, we want to look at the hematocrit and also the acidosis. So that's why we take ABG. Not really ABG, we can do VBG also. And then look at the metabolic acidosis and lactate clearance. For imaging parameters, I don't remember this whether tapi belajar je dulu. So imaging parameters ni apa yang I mentioned before about IVC collapsibility index. So basically we will measure the IVC diameter during patient inspire and expire. So we'll get this Cavill index. So if the Cavill index is 100%, so maksudnya apa? Expiratory minus inspiratory divided expiratory, maksudnya kita boleh tekan we can push the IVC up to the kita kata nipis. They are becoming flattened, yes, becoming flattened. So maksudnya almost complete collapse. There is volume depletion. And if Cavill index is 0%, so it means that there is not much of collapse. There's still fluid in there. So most likely patient is volume overload. So this is what parameters say. So if we give fluid, but then the collapsibility index tu doesn't improve, maksudnya from 100 doesn't improve to 40% ke apa, so patient is not responsive to our fluid. Faham ke? You can ask question after this or just message me. Alright. So after we look patient improve or not, if patient is improved after initial 5 to 10 ml per kg per hour tu, so is not improving. Basically ini sama je dengan algorithm A. If patient is not improving, so we can see that kita tengok hematocrit dia. If hematocrit dia tadi macam tadi becoming low but patient is not stable, so kita kena suspect patient is bleeding. But then if patient hematocrit increase, kita sama juga macam tadi, kita akan bagi colloid. But if patient is unchanged hematocrit, we have to refer to evidence sini, kita tengok nanti. So after second, lepas kita bagi steroid mula-mula and then we give the colloid the second time. If patient is improving, that's good. Refer back to tadi yang the reducing trend tu 532. If not, kita tengok balik, we check back the HCT and samalah. Alright. So this algorithm C, ini macam do not really have to tahu details, but just know that there are 5 other causes of why patient have shock in dengue. So septic shock, bleeding, cardiac dysfunction, severe metabolic acidosis, and cytokine storm. And this is the specific management for them. Just know the principle of that. So if septic, patient vasodilation, so we give NORAD to vasoconstrict the vessels. If it is bleeding, macam Mr. always say, just stop the pipe. Kan, kita look for source of bleeding, stop the pipe, and then we supply with them with blood lah, transfuse red cells. And others you can go back and read. Okay, so for monitoring, this is the principle. So know that we have to do a thorough review. And then we have to manage the patient not based on just diagnosis, but then based on the phase and severity of disease. This is very dynamic. Always kita kata review the patient, document the findings. Kalau perasan in the ward ada this white sheet of paper tu, this is inpatient dengue monitoring chart yang dia orang tulis dia punya vital signs, the symptom and berapa fluid yang kita bagi. And then during critical phase, kita kena frequently adjust the fluid, and in recovery phase, we have to reduce the fluid. Dia sama je lah CPT, you can go back and read. Basically, you can know that the frequency of monitoring is different according to the phase. Alright, so when to discharge patient. So once patient improve generally, and then patient is febrile without antipyretics for about 2 days, and then the lab tu dah makin okay. And then last kali the complication is recovering. Ni maksud stable hematocrit ataupun ni ialah, it means that it's not necessarily normal, but then it's recovering. Do you understand? Right. So always remember when to admit and when to discharge is by looking clinically, and then looking at the lab, and also of course the social factor tadi untuk admission. So yang ini just a quick trivia. Dalam CPT I mention this because sekarang duduk rumah, so always macam orang tanya kan, can we eat sup ketam kan. So basically we can see that all of this supplement according to scientifically evidence, if not proven lah to be, kita kata, prevent the complication or expedite the recovery. But then we have to advise patient that the important thing is that for them to increase the oral fluid intake. And then because some of this treatment is targeting the platelet count, but we have to remind them that to understand that it's not only about platelet, but it's also about the plasma leakage. Okay. But if contohlah mak kata nak juga bagi minum, for me tak tahulah, mungkin lecturer have different ke apa, boleh tanya lecturer, tak salah nak cuba, but then don't kita kata they have to also abide by the management plan by the doctors. Alright. And that's all. Next. Thank you. Ada soalan ke?
If there's any question, you can either open your microphone or write in the chat box. We'll wait for 10 seconds to look if there is any question.
Okay, rasa tak ada dah. So closure comment last kali is dengue is very simple. Baca banyak kali so that you can remember and understand it. And then memang the kita kata cara paling terbaik to understand dengue is you have to go back to patient. Cari seorang patient, follow them from dia masuk sampai dia discharge. So after that you will really understand what is the management